Excellent. Thank you so much for the introduction, Jessica. And I'd like to welcome all of our panelists today. So my name is Emily Rigby, and I'm here today representing the AIMC as well as Canatrek. And so we're just going to kick off this panel, and I'm going to let each of the panelists introduce themselves. So I might begin with yourself, Jerome, if you would like to give a brief introduction.
Yes, hello, my name's Jerome Sarris. I'm based at Nickham Health Research Institute at Westmead, but I'm currently bunkered down in Melbourne, in COVID Central, and I'm a researcher, academic by trade. My main area of research is doing randomized clinical trials, double-blind trials, looking at psychotropic plant medicines as well as nutraceuticals, and I also do some lifestyle medicine work within the realm of psychiatric disorders.
Great, thanks, Jerome. Great to have you with us today. And David, would you like to introduce yourself?
So I'm David Castle. I'm Professor of Psychiatry at St Vincent's Hospital and the University of Melbourne. Very long-standing interest in cannabis. My mother, Frances Ames, did one of the very first studies in humans dating back to the 1950s. So it's a heritage which I have. So it's great to join the panel. Thank you.
Thanks, David. Jamie, would you like to introduce yourself?
Yep, my name's Jamie Rickcord. I'm a GP in Byron, the North Coast, New South Wales. I have recently opened one of the first clinics focusing on cannabinoid medicine in the region, which is not a very hard job, as it turns out. And my major interests are in mental health, psychotherapeutic interventions, and novel pharmacotherapies to treat mental health disorders.
Great, thanks for joining us today, Jamie. And Danny.
Thank you, Emily. So hi, everyone. My name is Danny. I'm a GP. I'm also the medical director and the principal physician at Australian Cannabis Clinics. I have an interest in medical cannabis and I guess of its particular usage in mental health management due to extensive time in university health practice. Whereas I guess this was what we will say a bread and butter presentation in terms of uni health service. So yeah, this is how I come to this space, and yeah, good to meet you all.
Great, so we've got an excellent panel today to talk about medicinal cannabis and psychiatry and mental health. And I think I just wanted to kick off the panel and talk about some of the major risks and concerns of prescribing medical cannabis for psychiatric conditions. There's been plenty of media, whether or not it's had evidence to support it, that has talked about, some of the risks of cannabis and causing psychiatric conditions. But I thought if we could sort of just kick off with your experience and some of the evidence that you've seen in regards to cannabis and mental health disorders.
I can kick us off if you like. So, I mean, I think it's important to delineate most of the literature about concerns in people with mental health problems comes from not the use of medicinal cannabis. It's from the use of plant product and often in quite high concentration of THC. So THC we're particularly worried about because it is psychotomimetic and certain people are vulnerable to those effects. So there's some beautiful general population studies showing if you have psychosis proneness, which can be measured dimensionally, you're more likely to have an adverse reaction with psychotic-like symptoms associated with the use of THC, especially high concentration plant. And the other thing is the plants, of course, now have very little CBD, so that you don't get that sort of buffering antipsychotic effect. And if you take the extended dimensional approach to psychotic disorders, the people at the extreme end of that dimension would be people with a psychotic disorder like schizophrenia, and they would be very, very well advised to avoid THC at least. So I think that's mainly where the literature on adverse effects in mental health come from. There are also some signals about higher THC and depression as well, but the real concern has been about precipitating psychosis in vulnerable people.
Yeah, absolutely. And a lot of that data comes from the UK and there's some European data as well showing that. I mean, the main concern is a lot of these skunk varieties, and you can get that usage being fairly common. I spent a few years as late teenager, early 20s gentleman.
You don't have to self-divulge too much, Jerome.
No, I'm just saying I won't. I'll plead the fifth. But there certainly was a lot of skunk use around that in a youth population. I think that is one of our major concerns. Is sort of more of the illicit type of.
There are also concerns about particularly skunk and cognitive impairment. I think that in adults, it's probably only if you use very, very high amounts, very high potency for a very long time, and then you can get a sort of a motivational syndrome. But there are concerns about use in youth, and I think that those are very real concerns because you know, the teens in particular, a period of extreme, brain development, pruning of neuronal networks and so forth, and there are concerns about impact on cognition in young people, and of course, also concerns about placental transfer in pregnant women.
And just to clarify, when you refer to skunk, are you sort of referring to very high THC chemovars?
Yep.
Yep.
Yeah.
So some nice work, especially from Marta Di and Robin Murray in the UK, looking at this, and there's quite good correlations with the higher concentration of THC, the lower concentrations of CBD, in plant product being particularly pernicious to, as I said, vulnerable individuals. There's also concern that in fact in some people it might even be a causal contributory factor to schizophrenia. So I mean the general health messaging here would be avoidance of THC at least in people who are vulnerable, but also I would extend that to family history of psychotic disorders, and also in people at vulnerable stages of cortical brain development.
I think if you're talking about misuse of the plant, it also ties into prohibition. The people growing super skunk or skunk and their motivations and the genetics of the plants they're using are not the same as, medicinal use, medicinal growers, better genetics, fuller terpene profiles. And that's a completely different use to the illegal use of super skunk in places like London with vulnerable populations. And muddying the two is not really wise because they are two different things really, entirely.
Jamie, I agree. And that's why I prefaced my comments by saying that the literature which has been of concern has been from use of plant products. So it's a completely different landscape with medicinal use.
Yes, for sure.
But there's still concerns, if you're using relatively high THC products to certainly screen for psychotic disorders.
I agree. And I think that, even that research that's possibly pointing at a different cohort, there's a lot of useful information in that, which is using high THC in people with potential psychiatric problems. And it's a no-no, isn't it? That's quite straightforward as well, I think.
Yeah. So we would probably extend that to bipolar. I mean, there's very little research literature on it, but bipolar doesn't seem to be the best. Although quite a lot of patients still use it for its sort of soporific effects and reduction in anxiety, and some patients with bipolar swear by it, but the literature would suggest it's not a good idea.
Yeah.
Oh, go ahead, Danny.
Sorry, I second what all our esteemed panelists have said. I think, I think it's a very valid point that, people are a little bit concerned about it. And I think it comes back to, the literature. What the literature is, at the end of the day, we do, practice evidence-based medicine, and a lot of the sort of, I guess, concerns are based on, recreational THC usage. And so, the data yet on medical cannabis and, its effects and things like that in psychiatric condition is still to come out. But I think it is wise to play on the safer side and obviously screen for, personal or family history of psychosis, because, very much so that THC can exacerbate that. And at the end of the day, I think what we should try to do is, as the mantra with sort of medical cannabis is, start low and go slow, and that's, the way to go forward.
Yeah, Danny, also, I mean, to say that this might be the obverse for CBD, because there's some evidence, although conflicting, that CBD might actually be have antipsychotic properties. So there's a number of trials as I said, there's a number of trials which don't support it either, but it's certainly an interesting area, and it does seem to, in plant product, have a buffering effect.
And this is what I find really interesting when it comes to affective disorders. So looking at mood disorders, which can also include bipolar disorder, is that there's interesting data coming out, and unfortunately it's mixed. So there's not a clear message in terms of the THC CBD debate, and we've got a little bit of information about terpenes such as D-limonene and linalool, which can have anxiolytic effects and mood elevating effects. But it's interesting because the people who who take the cannabis sometimes will use higher dose THC and find that it's better for their mood. They use it for sleep. They might use it for the corollary of a pain disorder. But also for them, they don't find it anxiogenic. Whereas the data is saying, no, it's more the CBD and it's more protective. But then the information coming out of some of the cannabis clinics, as well as from apps such as Strain Print and Relief, is showing that actually in real life, people are tending to still want to have higher dose THC for some of their mood and anxiety disorders, which is really quite interesting because you wouldn't think that would be the case based off the evidence.
Yeah, THC, of course, causes inevitable tachycardia. And if people have a propensity to anxiety, they're going to misinterpret those somatic symptoms of elevated heart rate in a very catastrophic way. And that'll lead potentially to precipitation of panic. I've certainly had a few patients who tried cannabis once and they had a panic attack. Other people who don't have that propensity or who are using a more CBD-rich product find it very soporific and very helpful for anxiety. But Jamie, you were talking about some interesting stuff about the different mixes of product available in Canada. Australia, of course, we have relatively limited availability. Can you pick up on that a little, maybe?
Yes. So talking to lots of Canadians, they are at a stage in the industry where they're much more aware of terpene profiles in the products and the genetics of the plants. So, a 10-10 ratio, some of the doctors will choose a different 10-10 ratio based on the terpenes that they know are in that product. And then they'll use different ones maybe for anxiety or for pain, or whereas I think a lot of the products here, it's 10-10 ratio, and actually getting the details about the terpene profile and then how we apply that terpene profile to our patient's treatment is not, it's there, but you have to some of them it's there, some of them it's not. And it's a bit of a struggle to get that information, but it would be really nice to have it, stamped. This has got X, Y, and Z in it. And then we know that that's good for anxiety, and this one's good for sleep, and this one's good for pain and inflammation. And for that to be much more obvious for us as we're choosing which products to use for which conditions. But that will evolve, I hope.
Have we got that level of detail, or some level of detail, in the Australian market at the moment, especially around the terpenes and what's in the products?
For some products, but I think it could be made, as a practitioner, it would be lovely to have it made a lot more obvious. This company's 10-10, this is what's in it, these are the major terpenes. Yeah. And then I think as we're educating doctors, we need to be focusing on the kind of what different terpenes are and what they're doing basically and what their effects are, because that's not a lot of the cannabis education in this country doesn't really go into great detail about that. What's the difference between limonene and myrcene? How are they working? What's the sort of scientific or the kind of principles behind that? And that would be very useful, and I think it will improve patient outcomes, and that's
I think it's been a very blunt messaging so far. It's been about delta 9 THC, and CBD, and we know there's lots, huge number of other chemicals like delta 8 THC, for example, might have some important things, terpenes, as you say.
And these are sort of the intricacies of the science, isn't it? Because when I'm prescribing, I'm often thinking about what's going on in the kind of endocannabinoid system. What's the actual pathophysiology? But I'm prescribing for symptom control. That's what we're doing. We're not prescribing to treat schizophrenia. Maybe there's a dysregulation of the endocannabinoid system in the hippocampus and the cortex and the amygdala, and then that's contributing to the actual disease process. But we're not treating that; we're treating symptoms, you know. So there's a lot more inquiry into how, you know, what's the disease process in schizophrenia? How's the endocannabinoid system involved in that? And then how are we using cannabinoids to treat it, as opposed to treating anxiety or PTSD, the symptoms of, not the disease process in, you know?
Yeah, so I mean, it's like the rest of medicine, I suppose, is listening to patients, listening to their particular profiles of symptoms and what they want some help with. And certainly always asking about why they would use illicit cannabis, because certain people have certain particular reasons for wanting to use it and find it very helpful for certain symptoms. I'm wondering, Danny, should we bring you in and...
Yeah, I think it's a very good point what Jamie raised about, you know, we're describing this for, you know, symptom management. You know, as I see it, most of the time, you know, we're using this as an adjunctive management to what's already in place. And if we're talking about psychiatric management, you know, we're not trying to override what's already there, you know, put in place by their treating doctors, their psychiatrists, you know, you discontinue your counselling with your psychologist. So I think that's the thing. I think it's important to sort of educate both, you know, our fellow clinicians about, and also the general public. And I think that's how we're going to get sort of, I guess, a better traction in terms of, you know, people, you know, coming along, you know, saying, you know, look, there isn't, you know, there's some validity to what these guys are doing in terms of, you know, where medical cannabis is going. And I think that's the important message we try and drive across to people.
So Danny, have you had much pushback from medical colleagues who say, or Jamie, saying, shouldn't be doing this? There's a bit of a conservative environment amongst some of our colleagues in Australia. Hey?
Yeah, I don't know. I mean, you have to ask Jamie. I think he's positioned himself well by being in Byron, so that's helped. I'm in central Sydney CBD. My other role actually is working for the government doing advisory work. So I quite like to think I'm playing opposites in terms of the juxtaposition, in terms of I'm doing very heavily regulated stuff to something a little bit on sort of, I guess, a little bit off mainstream. But no, I think, you know, from my experience of talking to colleagues and just, you know, friends and just patients and things like that, there is, I feel, a greater acceptance anyway. I think they start to, you know, watch TV programs, go on the net, you know, so more and people are becoming aware, and they sort of, I guess, it's probably the challenge at the moment with our clinic and things like that is helping the patients and, you know, doctors connect with us. I think often a lot of them, you know, are still accessing, you know, cannabis products through the net and, you know, via sort of illegal means. And, you know, I think, you know, when they do finally come to meet us, they often say, you know, it was a bit of a struggle to, you know where you guys were. And so that's probably the challenge at the moment. Yeah.
How do you deal with people who just say your products are so expensive, I'd rather just use plant product?
A little bit of that, but often I kind of say, look, in terms of, you know, I think, you know, what they, you know, are using in terms of them accessing, you know, by sort of the back door, so to speak. I tell them, look, you can't really validate what you are getting in terms of, you know, mixture and stuff. And obviously a lot of them are using it by sort of, you know, smoking. And then so, you know, it's quite easy to say, look, there's, you know, the harmful effects of smoking that you can, you know, so, yeah.
Yeah, I think those are very important messages. Yeah.
I just see, Emily, we've got some questions.
Yeah, I didn't want to interrupt. It's all very interesting conversation there. And I think one of the things that's been raised, you know, in regards to the actual medicines and the different formulations that are available in Australia. And I thought we've had a couple of questions come in that do relate, you know, to whole plant extracts versus isolates, as well as some other, you know, comments in regards to the black market and accessing it through legal pathways. But if we were able to have a more diverse product range, which which we definitely are coming to get ever so slowly in Australia, what's sort of your opinion on, if you could have that cannabinoid and terpene profiles, are you after the more full spectrum products, or would you be looking at the isolates? And how much evidence is there out there to assist you to actually select, some of those minor cannabinoids and terpenes to actually match those with the different indications that you're trying to treat for symptom management?
Good question. It's a hard one to answer. Is there, it's an ongoing debate, isn't it? Extracts, isolates versus full plant. I think anecdotally, most patients prefer full plant extracts, full plant products. I think we're kind of in the early stages in this industry and understanding it in Australia, and we need more doctors with bigger numbers than possibly exist at the moment to really start teasing out what's working and what's not. And that, again, that's based on personal experience. If you're talking actual hard evidence of what's going on, that's a way away, I think, and expensive, so even further away. Yeah, I think, and it goes back to this idea of treating symptoms. Full plant terpenes is much more important. If we're treating, if we're attacking cancer cells in a tumor, then probably full plant versus the actual minor cannabinoid that's actually attacking that cancer cell is different. But that's two different things: symptoms versus the pathophysiology of the disease. And we shouldn't get them mixed up, because they're separate,
And does anyone have any recommendations from their experience then in prescribing what has been more beneficial for things like anxiety or PTSD and other mental health issues?
My experience is quite limited, but CBD seems really helpful for some people for sleep and anxiety. And there's some evidence, of course, to support this. The other thing we're seeing quite a lot is people with pain syndrome. So there you do need some THC. So it's a bit of a balancing act, and patients can actually do this themselves. They can get THC-rich and CBD-rich oil, and can sort of mix and match a bit, which I think is not a bad way of going, if you're monitoring closely what the efficacy is.
And that, yeah. I must admit, I will say that from what I understand in regards to the data, that there is obviously a major focus, obviously, with pain, anxiety, insomnia, some mood management. That is what mainly people are using it for. But a lot of the time, they're not using it for one particular symptom. It's you know what I mean? It's the corollary of a range of these symptoms, and that's, I guess, a regulatory thing in terms of when you get it prescribed, you have to focus on one particular disorder, whereas that's not how people are using it. And I just make another comment that I've got a colleague, Scott Shannon, who's an amazing guy in Colorado, he's a psychiatrist. He prescribes a lot pediatrically, and he does a lot of work with CBD with kids with insomnia, trauma, and a range of issues. Now, I don't know if that's something as an example which could be prescribed via our system, because maybe it doesn't meet the threshold of a particular disorder. And I think that hopefully we'll move towards having a greater understanding in terms of the more flexible approach and how it's actually being used, and accepting that through a medical system rather than being very disorder specific. And also understanding the interface from a personalized medicine perspective about the range of different cannabis compounds and preparations we can have. We're not quite there yet. There is data which is evolving, but we also have to consider, well, how does that relate to a person's individual genetics? How is that relating from the pharmacogenomic side? Also from their trait, their psychological state. Some products may work really well for one person, not the next person. May not necessarily be to do with the product, it's to do with the individual as well. So it's that interface we're learning more and more about, and it'll take a bit of time to get more understanding.
Yeah, definitely sounds across the board that it is really a personalized medicine, the way that that it interacts with our own sort of endocannabinoid system, which is, you know, very much like our fingerprint. It's very unique.
Yeah.
So if we're looking at prescribing for symptoms, for example, for PTSD, how can doctors take a personalized approach, and what type of cannabis medicines are more commonly prescribed for something like PTSD?
Well, I mean, personalized medicine is really what it says, listen to the person. So when you look at PTSD, I mean, PTSD is a very pleomorphic set of disorders, really. I mean, there happens to be trauma, of course, but the consequences of that trauma psychologically are very dependent upon who you are going into the trauma. So as Jerome says, you've got to take all that into account. But then listen to the patient and say, what are the particular symptoms you are most troubled by? And a lot of people with PTSD, what they hate is the night, because they know they're not going to sleep, and they know they're going to toss and turn, and they know they're going to have terrible nightmares. So with PTSD, it's often about the anxiolytic and soporific effects. Helpful with sleep. It has some other effects. I mean, some people with PTSD have been through physical trauma and have pain syndromes, and you need to target that separately. So it really is a bit of an art form, but as I keep on saying, personalized medicine's mainly listening to the patient.
Yeah, I mean, I'd like to see more with the genomics development in terms of understanding that. But just a final point, the THC is also shown to have fear extinguishing properties as well. So they tend to use a preparation which does have a higher THC concentration, to my understanding. But Jamie and Danny obviously would be able to speak to that better.
Well, my approach, the word's come up a few times, trauma, and the trauma has an effect on our nervous systems. It up-regulates patients. They're in a more sympathetically driven space. The amygdalas are large. They live in their limbic system. And that then drives anxiety. It drives disconnection. It drives insomnia. And these are the symptoms that we're treating. And whenever I'm treating PTSD or anxiety, I tend to use a lot more CBD than THC. But I find the CBD with the right amount of THC really just drops them into a more parasympathetic place, and then that way their symptoms are resolving, because that's what we're doing. We're improving their well-being. They may be able to kind of process some of those difficult emotions better that are coming up because of their kind of trauma state, the trauma physiology. And, especially compared to antidepressants or benzos, a lot of patients say that they numb them, they disconnect them from themselves. Whereas if we use the right amount of cannabinoids, we can really down-regulate them without disconnecting them from their emotions and themselves, which is improving their quality of life. And that is personal medicine, and that is individual for every single different patient. But you can't go wrong if you start with fairly big doses of CBD and then sort of slowly increase the THC until they find what you would call the sweet spot, basically, and then their lives improve. The pathophysiology, the effect on the endocannabinoid system, its effects in the limbic system, the amygdala, that we don't really understand yet. That will come, I hope, in the next 10, 20 years as we do more research.
I think just to add to Jamie's point about, treatments, conventional treatments like antidepressants and things like that. I think sometimes what we find as clinicians is, I think, in PTSD, depression, we tend to treat patient in terms of what we think they need to get to. So, for example, in depression, we don't want them to get too depressed, and we want them to, obviously remove those suicide effects in terms of suicidal ideations, etc. Right? But when you talk to patients, they kind of go, well, that's great, but what I actually want out of this is I want my quality of life back. And I think this is where, I think, in this space, we're able to, particularly, when you consult with patients, you talk to them, and we talked about a personalized approach, looking at, what are the goals they're trying to get out of this. And I think this is where we're able to sort of, I guess, fine tune things and try to sort of, I guess, get them, to get that quality of life back, not just to remove being, depressed or feeling sort of numb and things like that. So, yeah.
And we've heard from some speakers already today, you know, one of the barriers to achieving that wellness and that symptom management is the cost of cannabis medicines, particularly in Australia. In regards, for example, to PTSD, do you think the Department of Veteran Affairs, this is a question that came in earlier today from Lucy Haslam, do you think the DVA should actually be able, you know, to step up and actually pay the cost of these medicines for these veterans, particularly if they've got the gold cards and are approved for medical cannabis, especially when a lot of them say they experience financial hardship and therefore cannot afford it?
They will. I've got a question about that maybe David could answer, because I've got quite a few vets that I've been looking after for a number of years before I was doing this who have PTSD. And DVA said that they would pay for their medicines if a psychiatrist would write a letter saying they've got PTSD and that they agree with the use of cannabinoid medicine. And I've approached a couple who've actually said, well, the College of Psychiatrists doesn't agree with the use of cannabinoid medicine. Therefore, we can't write that letter for you.
Oh, wow.
And I've spoken to other psychiatrists who said that's not true. So, you know, I'm not out to pick a fight with anyone, but I would like to know where the College of Psychiatrists actually sit on that. Because if there's not enough evidence for them and they're not going to agree, that's fine. We need to get the evidence. If that's not the case, then it's finding a psychiatrist who is happy to give some people some CBD, basically.
That's your man. He'll give you a letter, don't worry.
That's why I'm asking the question.
Well, I can't speak on behalf of the college, of course, but I'm a fellow of the college. I mean, like all colleges, they tend to be rather conservative about things, but they can't dictate to practitioners what you do or don't do. You know, that's an APRA regulatory thing.
Right.
I stand to be corrected, but from my personal perspective, I wouldn't have thought that making a diagnosis, which is what psychiatrists certainly can do, and PTSD is a recognized psychiatric diagnosis, and making a comment that this particular medication seems to be beneficial for this particular patient, I don't think that that's putting you in any risk of being sanctioned by anybody.
Yeah.
I wouldn't have discomfort writing such a letter.
Yeah, I mean, it's interesting, isn't it? Because it goes back to the politics of the plant and the ongoing politics of the plant, you know. And I guess that's why we're all talking, because we'd all like to see it change. So.
Yeah, well, I mean, I think we absolutely have to recognise that there is huge ongoing morbidity within the general population in terms of psychiatric disorders. I mean, PTSD is one thing we're going to see that increase after COVID. There's no doubt.
Mm-hmm.
All sorts of need. I mean, goodness knows how many patients I'm seeing who, especially in Melbourne, are increasingly anxious and not able to sleep at night. I'm not saying cannabis should be put in the drinking water and the answer to all of them. But gee, there's plenty of them who conventional meds as we have them don't touch sides, and they're left struggling, suffering. So we need to be open to this. I mean, it's not just cannabis. Jerome and I have an interest in psychedelic medicine as well, and we'd make the same argument. We need to advance the science, and Australia has been a bit on the back foot, unfortunately, with regard to the science. We really need to step up and open the debates and open the availability and get, the sort of stuff we're getting, especially from Jamie and Danny here, is about use in true life and in real patients, and that's the most powerful messaging. And these are not particularly dangerous compounds. I mean, cannabis, as we said, there's some concerns about it in particular vulnerable individuals who are using high THC, but the medicinal compounds are, you can say, you know what's in them. So you can make a informed decision with the patient around what you use and what compounds you use.
And I think that's a narrative we all need to push as well, both for cannabinoids and psychedelic medicines, that this medicinal use of these medicines with trained professionals with evidence to back us up. And we are not doing the same thing as going to festivals or promoting that people buy their marijuana from the hills. They're two separate things, and we just need to keep hammering that message home, because it's different. It's not the same, and once people start to understand that, it's going to improve for everyone, all our patients, basically.
Same for psychedelics.
Yes, even more so for psychedelics. Say psychedelic, people, you know, they really run away. But
some people run.
Some people do, yes. But once, I mean, I actually think the take up for psychedelics will be faster than cannabis once the laws start to change, because, you know, the evidence is probably, you know, some of Rick Doblin's evidence is probably slightly more overwhelmingly positive than some of the evidence that exists for cannabinoid medicine.
So simpler because you're not using a plant product.
Yeah.
And that's one of the problems, isn't it, with cannabis? One is obviously the history and all of that, but the other thing is it's such a complex plant.
Yeah.
As you said, Jamie, a number of times, you know, the admixture of all these different things in a particular plant makes a heck of a big difference.
Yeah.
Yes. Now, I hate to actually cut this conversation short. We're actually running out of time, but I think there's some really valid points that were raised at the end. And I think, you know, the more we can get together on forums, you know, such as this symposium, and collaborate and work together, share our research, you know, our N of 1 trials are, you know, are going to actually, you know, with what Jamie's experience, for example, with some of his patients is really where a lot of this evidence comes from. And David, you do point out, you know, cannabis is a very complex plant-based medicine, and it's not as simple. But I think, you know, we're on the right path. I think there's a huge benefit, you know, with, as you mentioned, a lot more mental health issues coming out of the COVID pandemic. And I think cannabis has a role to play to help treat mental health, as well as stimulate the economy. And I hope we can continue some of these conversations offline. But it's really great to have you. Thank you for coming on board today.
Thanks.
Thanks.
Everywhere. Thank you.
Thanks.